Welcome back to Living Your Senior Life, the podcast where we talk about the things that actually matter as we get older, staying healthy, staying active, and making the most of every season of life. Today, we're diving into a topic that seems to be coming up everywhere. We're talking about GLP-1 medications. You've probably heard names like Ozempic, Mounjaro, and others that have been all over the news lately. These medications started as treatments for type 2 diabetes, and now they're being widely used for weight management too. And the big question a lot of us are asking is, are these medications actually a good option for older adults? Today we're covering the potential benefits, the risks seniors specifically need to be aware of, and the important questions to ask your doctor before ever considering one of these medications. Before we jump in, a quick reminder that everything we share today is for informational purposes only and is not medical advice. Always consult your own healthcare provider before starting, stopping, or changing any medication or treatment plan. So grab a cup of coffee, tea, or your water, get comfortable, and let's get started.
Right now, you look at Hollywood, and they're treating these new weight loss injections like a glamorous magic eraser for stubborn fat.
Yeah, absolutely.
You see the red carpet photos and the influencer hype on social media, and it just looks like a miracle, right?
It really does.
But, you put that exact same miracle drug into the body of, say, a 75-year-old, and suddenly, well, you aren't just erasing fat, you might actually be erasing their ability to walk up a flight of stairs.
Exactly. And that contrast right there is the precise reason the medical community is treating these drugs with such intense scrutiny right now.
Yeah, I imagine so.
Because when you step out of a cosmetic clinic and into a geriatric practice, you quickly realize you are dealing with a highly complex double-edged sword. Altering the metabolism of an older adult is, it's a massive biological intervention.
Which means we really need to look past the celebrity gossip and figure out what is actually happening on a cellular level. So welcome to the deep dive.
Glad to be here.
Today, we are focusing our attention on an incredibly detailed article from LivingYourSeniorLife.com. It's titled GLP-1 Medications for Seniors: Benefits, Risks, and What You Need to Know.
It's a fantastic resource.
It really is. And our mission for you today, listening, is to unpack exactly what these medications do to an older body. Because, as we're going to discover, for seniors, the goal isn't looking thin in a swimsuit.
Definitely not.
Right. It is about something much more fundamental, which is preserving independence. So, okay, let's unpack this. The source highlights a massive paradigm shift in how we even, talk about weight in a medical setting.
Yeah, the shift is truly foundational. For decades, the medical community and just society in general treated carrying excess weight as a moral failing.
Right, just a lack of willpower or whatever.
Exactly. It was framed as just eat less and move more.
Yeah.
But that older paradigm has been completely dismantled. The medical establishment now officially views obesity as a complex, chronic metabolic disease.
Oh, wow. So it's recognized as a disease?
Yes. It involves genetics, hormone imbalances, and neurological signaling. By reclassifying it as a chronic disease, doctors finally have the justification to use serious systemic tools to treat it, rather than just blaming the patient.
Which is a huge relief for so many people, I'm sure. But to understand why this shift is so impactful for seniors, we first have to look under the hood at the biology.
We do.
We hear these brand names constantly in the news, like Ozempic, Wegovy, Mounjaro, Zepbound. But let's demystify what they actually are. The article explains that these are GLP-1 medications.
Right, GLP-1.
Which stands for glucagon, like peptide 1. And the crucial thing to understand here is that this isn't some foreign synthetic chemical cooked up in a lab to melt fat. It is a naturally occurring hormone that your gut already produces every single time you eat a meal.
Exactly. The drugs we are talking about are essentially engineered mimics of that natural hormone. The research lists the specific active ingredients you might have seen on a prescription pad.
Like semaglutide, right?
Yeah, there is semaglutide, which is the active compound in Ozempic and Wegovy. Then there's tirzepatide, found in Mounjaro and Zepbound.
Got it.
And there is even a daily pill version of semaglutide called Rybelsus for those who want to avoid injections. But regardless of the brand name, they're all pulling the exact same biological levers in the body.
Let's talk about those levers, because the source breaks down 3 main mechanisms. And first, the medication actually targets the brain.
Right, it crosses the blood-brain barrier.
Yeah, and it binds to receptors in the hypothalamus, which is basically your body's appetite control center. It essentially blasts a fullness signal, tricking your brain into thinking you just ate a massive Thanksgiving dinner, even if you haven't eaten all day.
The neurological impact is just staggering. Patients describe the food noise in their heads just instantly going quiet, like a switch being flipped.
That's wild.
It really is. But the second mechanism happens down in the gut. These drugs actively slow down gastric emptying.
Now, I want to make sure I understand the mechanics of that, because earlier I was picturing this like a slow drip coffee filter where the food just physically moves slower through the system.
Right.
But it's actually more active than that, isn't it? It's almost like installing a traffic light at the bottom of your stomach. Instead of a green light letting food rush straight into the intestines to be digested, the GLP-1 medication turns that light yellow.
That is a brilliant way to look at it.
So it forces the stomach muscles to physically hold on to the food for hours longer than normal.
That traffic light analogy is perfect. The technical term is delayed peristalsis.
Delayed peristalsis.
Okay. Yeah, the muscle contractions of the stomach are deliberately slowed down. Because the food physically sits in the stomach longer, the physical sensation of being stretched and full remains for hours.
So you're getting it from both ends, basically.
Exactly. You pair a physically full stomach with a brain that is receiving chemical I'm full signals, and the desire to eat just plummets.
Then there's the third mechanism, which the article flags as arguably the most important for actual metabolic health. And that's the regulation of blood sugar.
This is huge, especially for seniors.
Right. So when blood sugar rises, these medications prompt the pancreas to release insulin while simultaneously telling the liver to stop pumping extra sugar into the bloodstream.
And instead of just forcing the pancreas to pump out insulin blindly, which is what older diabetes medications used to do, GLP-1 acts more like a smart thermostat.
Oh, interesting.
It only triggers that insulin release when blood sugar is high. This is why patients on these newer drugs don't generally suffer from the dangerous blood sugar crashes that older treatments caused. It is a highly targeted responsive system.
I do have a slightly dumb question about this, though.
Go for it.
So if my body already makes this GLP-1 hormone naturally every time I eat, why on earth do I need to inject a synthetic copy of it? Like, shouldn't my natural hormones be doing this traffic light and smart thermostat work already?
No, it's a great question. What's fascinating here is the difference in durability.
Durability?
Yeah. Natural GLP-1 is incredibly fragile. Your body produces it when you eat, but enzymes in your blood break it down and clear it out in a matter of minutes.
Oh, wow, just minutes.
Just minutes. So the feeling of fullness fades quickly. The synthetic versions, however, are engineered to resist those enzymes. They stick around in the bloodstream for days, sometimes a full week.
That makes sense.
Right, so by keeping those hormone levels artificially and consistently high 24/7, you get a powerful cascading effect across multiple bodily systems that your natural biology could never sustain on its own.
Because this synthetic hormone is lingering in the body for a full week, the effects cascade way past the stomach. We start seeing systemic changes, which completely redefines what weight loss means for an older adult.
Absolutely. When we look at the clinical benefits for seniors, we have to throw out the whole cosmetic mindset.
Right, it's not about the beach body.
Exactly. The data shows that just a 5% to 10% reduction in overall body weight profoundly alters the physical mechanics of an aging body. Every single pound of excess weight you carry puts about 4 pounds of extra pressure on your knee joints.
4 pounds from just 1 pound of weight.
Yeah. So if a senior loses 15 pounds, they have just removed 60 pounds of mechanical stress from their knees with every single step they take.
That is a staggering return on investment for the joints. I mean, wow.
It really is.
Plus, for seniors living with type 2 diabetes, the A1C improvements are massive. Better, stable blood sugar control directly reduces the long-term risks of microvascular complications.
Which is vital.
We are talking about protecting the blood vessels in the eyes, preventing kidney failure, and stopping nerve damage in the extremities. The source also notes that some of these medications have recently been proven to significantly reduce the risk of major cardiovascular events like heart attacks and strokes in people with existing heart disease.
It's life-saving stuff.
It is, but I am going to push back for a second, though. If you're listening to this and thinking about your own 75-year-old mother or father, They have their routines. Is putting their body through a major medication change, dealing with weekly needles, and altering their brain chemistry really worth it just to drop a few stubborn pounds?
Is the most important question a family can ask, really. And it requires us to completely reframe the narrative.
How so?
For a 75-year-old, this intervention is not about looking a certain way. It is strictly about extending their health span.
Health span. So not just lifespan.
Right. The period of life spent in good health, free from chronic disease and disability. Think about the daily reality of carrying excess weight with aging joints. That 10% weight loss is the literal difference between struggling to get out of a deep chair or dreading a flight of stairs versus having the stamina to safely walk through a grocery store, tend to a garden, or get down on the floor to play with grandchildren.
Yeah, I mean, it's the difference between being a spectator in your own life and an active participant. You are preserving their ability to live independently for years longer.
The reduction in joint pain alone means walking becomes an enjoyable activity rather than a painful chore. And that mobility is the foundation of an independent lifestyle. When you can move freely, you stay engaged with your community. That is the true medical justification for prescribing these drugs to seniors.
But, and there is always a but, right? Altering the body's internal plumbing to achieve that mobility comes at a steep cost. And this is where the deep dive gets really critical.
Yes, it does.
Because when you force an older body to shed weight rapidly by basically muting its appetite, it doesn't selectively choose to only burn fat.
Exactly. And this brings us to the hidden danger that never makes the celebrity headlines, but is arguably the single most important physiological concept for seniors to grasp. Sarcopenia.
Sarcopenia, the natural age-related loss of muscle mass.
Right. As human beings age, our bodies naturally lose muscle tissue and function. It happens to everyone. Now, combine that natural gradual decline with the mechanics of a GLP-1 medication.
The slowed stomach and the brain signals.
Right. We established that the drug slows stomach emptying and alters brain signaling. The inevitable side effects of that process are largely digestive. We see significant rates of nausea, vomiting, diarrhea, and severe bloating.
Which leads to rapid, unintentional weight loss.
And when an older adult drops weight quickly because they are simply, well, too nauseous to eat, we hit a physiological crisis. The body goes into a mild starvation mode. It needs energy, and it doesn't care where it gets it. A huge portion of the weight being lost in that scenario isn't fat at all. The body is actively breaking down and consuming its own muscle tissue for fuel.
It sounds like burning your house's foundational wooden beams just to keep the living room warm. I mean, sure, you're losing the overall weight, you're heating the house, but you're actively destroying the exact structural support you need to keep the whole building from collapsing.
That is, if we connect this to the broader picture of geriatric medicine, that analogy is terrifyingly accurate. For an older adult, protecting muscle mass is literally a matter of life and death. Muscle isn't just for lifting things. It is a structural organ. It's balance. It protects brittle bones from impact.
So it's armor, basically.
Essentially, yes. When a senior loses too much muscle mass, we see a rapid cascade of dangers. An exponentially higher risk of falling, sudden generalized weakness, the inability to perform basic daily hygiene, and ultimately, the complete loss of independence and a move into assisted living.
Which completely defeats the entire purpose of taking the medication. I mean, if you lose 30 pounds, but you've burned away so much muscle that you are too frail to lift yourself off the toilet, you haven't gained any mobility.
Right, you've lost it.
You've just traded one form of physical restriction for another. The research makes it very clear. Weight loss from any source causes some muscle loss, making this an incredibly delicate biological balancing act for seniors.
And the physical structure of the muscle isn't the only thing withering away in this scenario. We also have to look at what's happening to the body's internal water reserves. Because GLP-1s essentially trick your brain into thinking you aren't hungry, they inadvertently trick you into ignoring your basic survival needs.
This leads right into what the source calls the hydration and nutrition trap. Let's tackle the water issue first. It is a biological fact that older adults naturally have a less reliable thirst signal, don't they?
They do, yeah.
As the brain ages, the neurological sensors that detect dehydration just don't fire as loudly or as quickly as they do in younger people.
Now imagine the compounding effect. You take a senior whose thirst mechanism is already blunted by age. You give them a medication that makes them feel constantly full, slightly nauseous, and completely disinterested in consuming anything, including liquids.
That's a recipe for disaster.
The danger of severe dehydration doesn't just increase, it spikes exponentially.
And what's fascinating, and honestly a bit scary, is the neurological overlap here. The brain's hunger center and thirst center sit right next to each other in the hypothalamus.
Yep, very close neighbors.
So by using a chemical to severely mute the hunger signals, you accidentally place a muffler over the thirst signals too.
The patient simply forgets to drink.
Yeah.
And in a senior, dehydration isn't just feeling thirsty. It leads to urinary tract infections, severe drops in blood pressure that cause fainting and falls, and acute kidney injury.
So what are the signs families should be looking for?
The warning signs to watch for are a persistently dry mouth, sudden dizziness when standing up, very dark urine, and unexplained mental confusion or delirium.
And it's not just water they're missing out on either. It is foundational nutrition. When appetite drops to the floor, some people are only managing a few bites of food a day. But a 75-year-old body still requires a massive amount of essential nutrients to function.
This is the malnutrition trap. When you're only eating a few bites per meal, every single one of those bites has to count. If a patient fills up on a plain piece of toast and a cup of black tea, they feel physically stuffed, but they have consumed zero actual nutrition. Seniors on these medications are at massive risk of developing severe deficiencies in calcium, vitamin D, dietary fiber, and crucially, protein.
So what does this all mean? I mean, it sounds like the paradox doctors are dealing with is that the medication is almost working too well. It's making people so apathetic toward food that they're forgetting they still need raw fuel to survive.
This raises an important question, actually the most important question of the entire discussion. How does a patient actually manage this metabolic intervention without becoming hopelessly frail?
Before we detail the exact playbook for surviving that paradox, we have to mention the severe, albeit rare, medical emergencies, the source flags. We're talking about gallbladder disease and pancreatitis.
Yes, you need to touch on those. While uncommon, the way these drugs alter digestion can occasionally lead to gallstones or inflammation of the pancreas. These are absolute medical emergencies.
And how would someone know if that's happening?
The warning signs are distinct. Severe, unrelenting abdominal pain that often radiates straight through to the back, persistent vomiting that won't stop, or a sudden high fever. If any of those symptoms appear, the patient needs an emergency room, not a glass of water.
Okay, we have thoroughly mapped out the minefield. We have the incredible promise of restored mobility and systemic disease prevention, but it is surrounded on all sides by the traps of muscle loss, hidden dehydration, and severe malnutrition.
It's a lot to navigate.
It is, but thankfully, living your senior life provides a very specific tactical playbook for any senior considering this route.
It is a rigorous playbook, though. It demands active participation. You cannot just take a weekly injection, sit on the couch, and passively wait to get healthier. You have to actively manage the body's changing chemistry.
Let's break down the tactics, starting with the dietary strategy. We established that every bite matters. The article's golden rule is to prioritize protein-rich foods first during every single meal.
Yes, first, always.
So before you touch the rice, the pasta, or the bread, you eat the fish, the chicken, the eggs, or the tofu.
The biological reason for this is simple. You have a very limited window before that fullness signal kicks in, and you physically cannot eat another bite. By eating the protein first, you ensure that the few bites you do manage to swallow are packed with the amino acids your body desperately needs.
You're fueling the muscles before you run out of room.
Exactly. You are giving your body the raw building blocks it requires to maintain that vital muscle mass, preventing it from cannibalizing its own structural beams for energy.
Then there is the hydration strategy. The rule is blunt. Do not wait for thirst. If you are waiting until your brain tells you that you are thirsty, you are already dangerously behind.
Way behind.
You need to carry a water bottle and sip constantly throughout the day, driven by a clock, not by a feeling. And you can sort of eat your water by heavily incorporating water-rich fruits and vegetables like cucumbers or watermelon into those small meals.
That's a great tip. And the third pillar is the physical action plan to directly counteract the sarcopenia. You cannot just eat protein. You have to signal to the body that the muscles are still in use. That means exercise, specifically resistance and strength training.
And I love that the article makes it accessible. Strength training for a senior does not mean deadlifting 200 pounds in a noisy, expensive gym.
Not at all. It means using a simple elastic resistance band in your living room while watching television. It means doing repetitive chair stands, simply standing up and sitting down slowly to build a quadriceps.
Just everyday movements.
Right. The biological goal is simply to create enough mechanical tension on the muscle fibers to signal the brain, hey, we're still using these muscles to move around, do not burn them for energy.
Finally, the playbook covers the administrative and medical conversations you must have with a doctor. These drugs are not a solo journey. The article highlights specific questions you need to ask. You need blood work to check your current kidney function. You need to map out potential drug interactions with medications you already take. And you need a brutally honest assessment of whether your current level of physical frailty makes you a bad candidate from the start.
Furthermore, there is the reality of the healthcare system. Medicare coverage for these specific medications varies wildly, and it all comes down to the specific diagnosis your doctor uses.
This is a huge point of confusion. Why does Medicare cover it for one person but deny it for their neighbor?
It comes down to federal law. Currently, Medicare is legally prohibited from covering any prescription drug that is prescribed strictly for weight loss. However, if a doctor prescribes that exact same GLP-1 medication to treat existing type 2 diabetes or to lower the risk of a heart attack in a patient with established cardiovascular disease, Medicare will often cover it. The drug is the same, but the diagnostic code dictates the coverage.
Here's where it gets really interesting, though. The source explicitly points out a common misconception about age itself. Simply being over the age of 65 is not a disqualifier for drugs like Ozempic or Wegovy.
That is a critical takeaway. The medical community does not treat a birth year as a contraindication. It is entirely dependent on biological age and individual health status. A robust, active 80-year-old with excellent kidney function and good muscle mass might be a fantastic candidate.
But on the flip side...
Right. Conversely, a frail 65-year-old who has a history of falls and previous bouts of pancreatitis would likely be denied the prescription.
It is about treating the biological reality of the individual, not the number on their driver's license. Synthesizing all of this practical advice, the overarching message is that starting a GLP-1 is a long-term medical strategy. It requires constant, vigilant monitoring of your energy levels, your physical grip strength, your daily fluid intake, and any digestive side effects. These medications are a remarkable paradigm-shifting tool for geriatric medicine. But they are just a tool. They require a skilled operator.
They require a user manual, and you have to follow the instructions meticulously. So bringing this all together, we are looking at a very delicate tightrope walk for seniors.
Very delicate.
On one side, you have the incredible, genuinely life-changing promise of renewed mobility, stable blood sugar, and a stronger heart. On the other side, you have the silent, stealthy threats of muscle wasting, frailty, and severe dehydration.
It is a profound balance of risk and reward that absolutely requires careful, ongoing professional supervision. Which is why we need to remind you, our listener, that this deep dive is strictly informational. It is based on the research presented in the Living Your Senior Life article. It is not medical advice. If you or a loved one are navigating these options, you absolutely must sit down with your own healthcare provider to weigh these specific biological factors.
The ultimate goal of geriatric care is preserving your independence and your quality of life. Only your personal physician can help you map out whether this medication is the safest route to that destination.
As we wrap up today's deep dive, thinking back to where we started, this total paradigm shift in how we treat the biology of weight and aging. I know you had a thought about the psychological side of this that really stuck with you.
I did, yeah.
Yeah?
It is something that wasn't explicitly covered in the clinical data, but reading about how these drugs essentially rewire the hypothalamus really brought it to mind.
What was it?
Well, if medical science can now install a chemical mute button for our appetite, how does that fundamentally alter our lifelong psychological relationship with food?
Oh, wow.
I mean, for decades, eating has been driven by craving, hunger, and satisfaction. When those biological drives are chemically silenced, how do we redefine the simple cultural joy of sitting down for a family meal in our golden years?
That is a profound philosophical shift, moving from food as an urgent biological drive to food as a purely conscious, almost mechanical choice. It changes the entire social fabric of eating. That is, well, a lot to chew on, pun entirely intended.
If today's episode sparked some questions for you, bring them to your next doctor's appointment. There's a full article on this topic over at livingyourSeniorLife.com. And if you found this episode helpful, we'd love it if you'd share it with a friend or family member who might be weighing this decision right now. As always, everything we share is for informational purposes only and is not medical advice. Please work with your own healthcare provider on decisions like this one. Thanks so much for listening today. And as always, until next time, take care of yourself and live your best senior life.